Hi, everybody. I hope you guys are enjoying using the website, and I hope you're enjoying seeing more nicely labeled videos and things like that. We had covered pelvic fractures, or at least looking at the pelvis, understanding why it's such an important structure, and you know, in all honesty, in 2 lectures, there's no way we can do justice to the entire pelvis. There's so many intricacies, so many oddities. There's so many things that you need to look at. And especially when you do orthopedics, you learn it a lot more when you rotate through orthopedics. Or if you have a chance to work in orthopedics, you'll see there's so much that has to do with the pelvis. So than concentrating on all the nitty gritties and all the different classifications and things like that, what I said was, let's rather just go through some of the things that we more commonly see, and just understanding how, like I said in the last one, how to stabilize and things like that. So now what we're going to do is that we're going to just look at some fractures. It's not going to be a very long recording, but at least it will be something that will allow you to, understand the basics of these types of fractures. So what you one thing I always tell people is that you've always got to look through an entire X-ray. We have a tendency of always looking at just the thing that's wrong and never considering, what else could be wrong, what else could be off, and things like that. So we're going to look at an easy fracture. Now, for most of you, even if you don't have much experience, you would recognize that a normal pelvis, symphysis pubis, does not look like this. All right, so this is what you call it, an open book fracture, right? So why we call it an open book is because basically that's what happens, Let me try and draw it out over here just so that you can get an idea. Let's just use a blue for normal. So if we had to look at the axis of the pelvis, how it would normally sit, you'd normally expect the two to actually sit like that, So that's more or less what we can see. Now we can see this one here more or less follows that. But if you look at this particular side, you can see that it's actually now moved away, So it seems to be sitting more in that direction. So what's happened is that there's now a gap, right? Even though it's physically there, you could sort of look at it as being that far. And the other thing that you can notice is that there's a rotation, So if you look at your ring over there, it's quite easily visible. And if you look over here between the rami, you can't notice it. So if you had to think of it in a 3D fashion, this is actually rotated in an anti-clockwise direction. So it's actually moved in that direction. Now, most people would stop there and say, okay, I know I've got an open book fracture. I know I've got to bind the pelvis. I know I've got to do a lot of things. And what you'd expect from this is quite a bit of blood loss because there'll be shearing of the vessels that we had looked at before. So there's quite a bit that's going to be going on with this patient. But the thing is, don't just look at the one part. Now, the reason why I mentioned that is because the pelvis is a ring. Right. So if you own a ring, seen a donut, whatever it may be, it's extremely difficult to crack a ring in one place. Right. And this is actually quite a common thing in a lot of the joints, So, for example, in your C-spine, we spoke about this as well. You can even talk about it in the ankle to some extent, even, one or two of the other joints also do that. So this is a pelvic ring, right, at the end of the day. So if you have a ring, now I want you to just imagine in your mind, let's put a ring up over here. Right. Let's just make it a different color. Sorry about that. Okay, so let's just make a ring. Okay. Okay. I started wrong. Let's just clear that. Just do that one. Let's just try it again. Hope we get to try it this time. Still didn't get it right. Okay, but just to let me just try one more time. Okay, yeah, I think that's better. So if you have to look at this as a ring, now what you're going to do is you're going to follow the entire ring. So we can already see there's a break in the ring there. All right, let's give it another color. Let's not make that. Let's just do that. So you can see that there is a break there, right? You can see that. Now you've got to look at the rest of the ring and try and see if there's anything else that's going on. And this is something that you should do whenever you're looking at these pelvic exercises. Now, of course, I don't mean follow this precise line. You're going to look around everything. And what you'll notice in this particular one is that if you look at the sacroiliac joint over here, this is also dissociated, even though not fractured, but it is dissociated. So it's moved away. So if you really look at this is almost equivalent to a flared chest, a flared rib, things like that, even though the ligaments may still be holding onto it. But essentially, your pelvis is not stable at all. Okay. So when we talk about stability, this is one of the things that we talk about. Okay. So this patient is at high risk for blood loss, is at high risk for an unstable pelvis. So in other words, if you're moving this patient around and you haven't stabilized that pelvis, this thing is just going to flop around, tear vessels, tear arteries, tear veins, destroy structures underneath, things like that. Now, whenever you have a pubic symphysis fracture, the other thing that you need to worry about is the urethral meatus. All right. So let's clear those drawings. All right. Let's try and put a little bladder in over here. Sorry. I'm just trying to get that. Yeah, be able to do it a bit better this time. So let's just say that this is where your bladder normally sits. Okay. And now you would be expecting your urethra to actually be coming out through. So it doesn't matter male or female, but that's your urethra. So as you can imagine, because your urethra is just posterior to these, to the pubic symphysis, there's a high chance of rupture. There's a high chance of injury that's going on over there. So whenever you have a patient like this, any open book fracture, whatever it is, you've got to check the meatus. So be it male or female patient, you have to check for the meatus. You have to know whether there's blood coming out of that meatus. You have to check if there's urine going in. Now, I would advise everybody that if you see that, or if it's a male patient, of course, check for a prostate. Your prostate, in other words, will just be flopping around. So it will be high riding. What that means is if you were to do a PR examination, you wouldn't find the prostate in its normal position, which is more or less there. Let's try and get that as well. Sorry about that. Let's try and get a prostate in there and make it a nice pink color. All right, so this is where you would expect your prostate to be. So what happens is that when you have any of these fractures, then your prostate may well move quite far up, and you may end up, when you're doing a PR, actually finding your prostate 1 or 2 centimeters higher. And of course, the urethra itself may be damaged and transected. So when you try and insert a catheter inside over here, you may inadvertently end up with the catheter tip going into the abdominal cavity or the pelvic cavity, if I can put it that way. So please be careful. Now, what they do advise, and what our urologists have told us on a few occasions, that attempt it once. But if there's no urine coming out, or if you get blood, then understand that you are not in the bladder, and there's a good chance that you may make the transection worse, in which case you remove and you get a urologist involved as quickly as possible. If you don't have a urologist involved, you just leave it, because your patient needs to be referred up to an area that has a urologist that can manage a urethral injury like this. Okay, so yeah. I hope that kind of makes sense as to what's going on. And remember, in the last lesson, we had talked about putting the pelvic binder and things like that. So once you put the pelvic binder, what's going to happen is, as you start pulling these trochanters together, you're actually going to move the pelvis, in the correct rotational axis, and you're going to bring it closer on this side. So you're going to decrease the chances of bleeding, which is the main thing. And you're going to stabilize it so that when you move the patient around, this entire thing is not just floating around in no man's land. It's actually got some support to it. So that's the thing that I would always advise people to do, stabilize it before you do anything else. Okay, let's go to another one. Oops, sorry. All right, so let's try and find another fracture. Okay, so here we can see that there's quite glaring abnormalities over here. Now, this also has to do with, I haven't really gotten into this because I thought it might be a bit too much for people to take in, but this has to do with the direction of forces as well. So, the pelvis can have force directed on it from the sides or from the front. And in this case, the force is coming through from the front, okay? So make sure you look at the entire X-ray. That's the most important thing. So we can see the pubic rami are fractured, okay, and with that, there's a movement away of the ilium over here, and we can see that there's a good chance, because there's bone shards as well, of intrapelvic injury and things like that. But if you don't look through the entire X-ray and you only look at this, you're actually going to miss the fracture over here. which is an acetabular fracture as well. And you need to follow the entire thing. And so we can see this is obviously an unstable fracture. We can see over here there's possibly an acetabular fracture over there. We need to follow up. And remember what I said, it is a ring. So you need to check the sacroiliac joints. So there could possibly be a dissociation, a movement away, even though it's not as obvious as the last one. And when you look through the entire X-ray, notice what you notice here. That you've got a sacral fracture as well, and the entire coccyx is dislodged as well. So in this patient, you're expecting numerous injuries to take place. Now, in this case, what has happened is this is actually a force from the, let's say, inferiorly. Um, um, when I say that, I mean it's coming from the front, but slightly inferior. So it's not a direct head-on hit. It's coming slightly from the bottom, but also from the anterior part. So you've got to think of that as well. Right? So all of this has been pushed back. The entire area has been pushed back, rotated in some cases as well. So what injuries are we expecting? We're expecting massive vascular injuries over here. We're expecting possible neurological injury as well. I mean, if we were to look at the L spine further up, we may find more injury over there, even though it's not as obvious on this one. And we would expect urethral injuries, prostate injuries. It's a male patient, obviously, so that's why I mentioned that. We'd also have to look for testicular injury, things like that, simply because of the direction of force, okay? And of course, with an acetabular fracture, you're going to get rotation of, the patient's going to be splinting their limb. You can already see there's a height discrepancy, there's swelling, there's so much going on. But the most important thing that I wanted to point out here is that this patient, you need to look at the entire X. It's very easy just to focus on this, or even if you catch that one, but if you don't go through the rest of it, you're going to miss all of this, right? So this is an S1, 2, 3 fracture, right? So S3, remember, has to do with anal tone. So this patient may not have any anal tone. It's possible. I'm not saying it's definitely there, but it's something that you've got to look at. Okay, so remember, and if you don't take anything away from this, even if you forget every single pelvic fracture, but even if you remember just to look through the entire X-ray, you'll have done quite well. Okay, let's go to another. Okay, so this is just a stable pubic rami fracture, right? So just to show you what it looks like, the inferior pubic ramus, right? So just to show you what that looks like. But you've still got to remember to look through the entire X-ray. So make sure that you look at the acetabulum, make sure you look at the ilium, make sure you look at the ischium, make sure you look at the symphysis pubis, make sure you look at everything so that everything is okay. One good rule of thumb, that the guys in orthopedics use is that from your head of your femur, neck of your femur, into the head of the femur and into the acetabulum, it should just be a nice continuous curve, so that's another nice thing to look for. And these are the types of things that you look for in this. But it can just show you that sometimes you can have these subtle fractures as well. Now, this is a stable fracture. You're not going to treat this with any sort of invasive surgery and things like that. These types of patients need rest and they normally heal on their own. Okay. So let's have a look at another one. So this is I wouldn't say a difficult one, but I mean, it's one that's quite easy to miss. So this is an acetabular fracture. So this is what your acetabulum looks like on a patient. Sorry, it's not the clearest image. I thought I made it a lot better. But you can see that looking at it in a 2D view, you can easily make out the fracture of the acetabulum. But look at it and see how far it has actually gone. You can actually see how extensive the fracture is. So acetabular fractures are not a minor thing. And here you can see it's even gone down here into this posterior part, inferior ramus over here. So you've got to make sure that you have a look at these. And from what I told you before, remember what I told you, that it should make a nice arc. And here you can see that it doesn't. There's obviously some disruption over there. So this is quite an important one to know. And it just shows you the extent of comparing a 2D to the 3D, and you can see how extensive the fracture is. So these types of patients sometimes need hip replacements. They often need what do you call these things? Implants to be put in as well. And sometimes they just need to be stabilized as well. Now, I'm not an orthopedic surgeon. I'll be dead honest. I did do orthopedics for a while. I hated it. I cannot stand the sound of bone crepitus. So I remember doing one of these procedures like 20 years ago, when we would still I mean, that's ancient now, when you really think about it. We used to drill holes in the head for headaches, and release the humors. No, I'm just kidding, that long ago. But what I'm saying is now I'm sure there's much more advanced ways of doing this. And I won't lie to you and say that I know exactly what they do in theater, because I haven't done that for quite some time. And just looking at it now from an emergency department point of view, which is a nice escape for me to say, I'm just looking at it from that point of view. So the most important, so let's have a look at this. All right. So here we see bilateral superior and inferior rami fracture. Okay. So a cone down is just the way that they take it. So they're actually taking it sort of from the how do I put it? Sort of like looking through the pelvis, if I can put it that way. The X-ray is pointed from the top downwards. So here we can see the fractures, and you can see how much of disruption there is over here. Okay, so these are some of the questions that you need to ask yourself. So, are you expecting a normal BP? Of course not, because you're going to have so much of vascular disruption over here. That you're going to, have a patient that's bleeding out quite badly, and it's quite difficult to stabilize these, especially when it's bilaterally, because once you pull this together, you're actually going to displace this more, but you still need to stabilize it as much as possible so that whatever is there is given a chance to tamponade. So even before you know what's precisely on the X-ray, the first step, if you suspect a pelvic fracture, and we discussed the clinical signs the last time, is that stabilize that pelvis. You will not do more harm. The only time you'll do more harm is if you pull it so tight that you're actually going to, disrupt the pelvis even more. So you've got to be reasonable as well, and make sure that you don't, as you're pulling, you're not getting severe bone crepitus, you're not seeing deformities occur. You just want to keep it as stable as possible. And if you're lucky enough to work in the private sector, at some point you'll have a pelvic binder, which I had shown you guys as well. And pelvic binders prevent all of this. For those of us who are working in public, rural, we often only have sheets. That's it. That's the extent of our pelvic binders, and you've got to use it exactly like how I showed you the last time. So what other related injuries are we thinking of? Now, we have already spoken about bladder, urethra. Here you can see a catheter that has been successfully passed. But in a female patient, you're also looking at vaginal, and in a male patient and female patient, you're looking at vaginal and rectal injuries as well. Now, what I will advise you is that if you are doing a PR on a patient with a suspected pelvic injury, please be careful when inserting your finger. And if you feel anything, I would suggest always double glove, because once you get poked with that, there's a high possibility of yourself contracting very, those organisms are highly, how can I put it, pathogenic. You can get severe sepsis yourself. So be careful. If you feel anything, just remove your finger. Don't try and push past and see what could be there and things like that. So, just acknowledge it and keep it at that, and make sure to start the patient on high dose antibiotics, because now all of that, especially with the rectum and vagina, it's the same as having an open fracture, but now you're dealing with feces, which I don't need to tell you how septic that can become. So you need to start treating these patients from that point of view. So how would you manage this patient acutely? Stabilize their BPs, make sure that you stabilize the pelvis, try and pass a catheter if possible, do your full examination, check to see if there's incursions into the pelvic organs, and then this patient needs an urgent transfer to an orthopedic unit, and in some cases, if you go to some of the bigger hospitals, tertiary hospitals, they even have, interdepartmental, like how you may get a spinal unit. I've seen one or two of the hospitals that have specific pelvic units as well that deal specifically with this. And, it's quite amazing. If any of you have a chance to do even an elective in a pelvic or a spinal unit, go and do it. It's really something to see. Okay. Let's have a look at another one. All right. So this is an iliac wing or Duvernay fracture. So this is not from direct trauma. So the patient's been hit from the side, okay, and it can be associated with localized ileus of the bowel as well. So I was actually quite surprised that this is treated conservatively, but it is treated conservatively. So the patient is placed on bed rest and things. And of course, even if you were to see this, you would go through the rest of it. So what happens is you have a force that's coming in from the side. Now remember, we're seeing it as 2D, but in essence, your iliac wing is actually curving around. So it's a force that's coming from that direction and then cause the fracture. Extremely painful, as any fracture is. But this particular one, extremely painful because every time the patient moves, they do suffer a lot of pain. So they're often given stabilization devices. If they're lucky enough to, well, in South Africa at least, we're lucky enough to be treated privately, they're normally kept on very high dose analgesia. There's specific types of stabilizing devices that can be used. Unfortunately, in the public, we don't have that. When I say the public, I mean the public sector. So let's look at some pelvic ring fractures. All right. So these are pelvic compression fractures. Okay. So we have looked at these. So what's happening is these are anteriorly directed forces. So the force is coming from the front. Okay. So what happens is that it causes a split in this particular one. And here you can also see the dissociation of the sacroiliac joints as well. And the similar thing here, so like I was telling you, you have to look at it as a ring. Make sure that you see it as a ring in your own mind. Think of it as a 3D object. And I know it's a bit strange initially. You may not pick it up immediately, but you've got to try. You've got to try and imagine it as a 3D object, and then it becomes much easier to understand how those forces impact. So in this particular case, let's get something going over here. So you have this anteriorly directed force. So it's coming from this side. So in order to prevent these rami being pushed in, it's similar to how the orbit is made and similar to one or two of the other joints. So in order to prevent that, what happens is that it dissipates the force. So you have this force that's initially coming from the front. And then once it hits the pelvic ring, instead of the force is being pushed in, the force is then pushed outwards in order to prevent injury to the underlying organ. So it's very well designed or evolved, whatever your leanings may be. I'm not talking about that. So what happens is that it then causes a split. Okay. And once you split a ring, that's when you start seeing problems that are occurring. Okay. So we can use this as an exercise. Let's try and have a look at it from another point of view, because I was hoping to talk about forces. So if you have a force that's directed from that side, for instance, let's say, so how do you think the forces are going to be dissipated? So the force is dissipated that way, and the force is dissipated this way. So in that case, what you may see is an overlap, fracture. So that's how you've got to think of it. Okay. And we are going to cover another one just now that I'll talk about a shearing type force that is a bit difficult. And why is this dangerous? Again, vascular injury. That's the most important thing. Of course, underlying organ injury. But in the acute phase, we are talking about vascular injury as being the most worrying one. Yeah. So that's something that you really have to think about. Okay, so always remember pelvic injuries, and when we get to the femur, we'll discuss it as well. Blood loss can be extremely severe. Make sure you get that patient as hemodynamically stable as possible. Now, for those of you who have followed some of our trauma lectures before, when we've talked about stabilizing, we're not talking about getting a BP up to 120/80. In fact, you're aiming just for a systolic of about 100 and diastolic of about 60 to 70. The reason being, once you stabilize this pelvis and you allow things to tamponade on the inside, those have formed very weak clots. That's what a tamponade is. It's a very weak clot. It's not a matured clot. It's not a fixed clot, nothing like that. So once you increase your BP too much, so once you get your BPs above 100, there's always a possibility that you're going to start shooting off those clots and they're going to fly off everywhere and you're just going to re-bleed. So in any sort of trauma setting, where the patient is, losing blood, has had a vascular bleed, that's what you're aiming for. Now, the only exception to that would be intracranial injury. We're aiming for a little bit higher, about 110, because you are trying to maintain a slightly higher cerebral perfusion. But anyway, that's another discussion altogether. Okay. All right, so this is a vertical shear fracture, and this is one of the most horrifying things to see. Now, I've picked a very mild one, actually, and I'm sure any of you who have been on the internet for any sort of time, especially on the meme sites and that, you see some horrific ones that come up, where patients have placed their legs on top of the dashboard of a car, and that's basically what we're talking about. So what happens is that, let's get that up again. So, sorry, just want to get this up again. So what we're talking about is we're not talking about an anterior. Now we're talking about, so I'm just going to try from a bit lower down. We're talking about an inferior force. So it's basically a force that's traveling in this direction. Okay. So once that happens, it basically causes the entire side that's affected to shear off from the rest of the pelvis. Okay. So in this case, you can see everything's displaced upwards, and in this case laterally as well, although it can be displaced medially, but it's more common for it to be displaced laterally. And you can see the forces come through on this side, and it's completely disrupted the entire pelvis. Now, of course, if that is directed through the femur, you can get the femur also being displaced upwards. If it's purely over the rama, you may see something like this. And of course, you'd expect some sort of sacral and coccygeal injury. And of course, your underlying injuries here, your bladder, your bowel, uterus, vaginal injuries. There's so many things that you could expect, and really, these are extremely difficult to manage. Stabilization still has to be done, but in these ones, this is where I would suggest that you don't stabilize it too heavily without too much force. The reason being you may well displace some of this even more and cause further bleeding. So it is something, unfortunately, that comes with practice, but luckily, these are not that common. When I say not that common, I mean, in our unit, we may see one a year or two a year, that's about it, which are as severe as this, of course. I mean, you do get, shear fractures that are not as severe. I'm talking about a severe one like this. In fact, I can remember one from about 2 or 3 years ago where we had a young gentleman who was actually on top of a tractor, and it lost control or something, and he fell down quite a large, quite from on top of the tractor, the back of the tractor, and he went down into a ditch. And it was his, I think it was left or right leg that actually hit the ground. So he had this force that moved up, and this entire chunk of the ilium was completely, lost and basically flail, if I can put it that way. And even when we were trying to stabilize it, it was almost impossible. You could physically feel it moving. And I still remember he's one of the few patients that I lost in CT, because we tried to rush him through to CT to see exactly how bad the injuries were, on request from the orthopods, and he passed away in the CT. And it was, one of the few losses we've had in CT in our department. But anyway, so that's another one to look at. Okay. All right, and we're coming closer to the end now, so we're just going to talk about the coccyx. So it's something that you need to look at. So the coccyx is quite easy to follow when you are looking here, and your patients may often feel like something moving in their buttocks. They themselves, when they press on it, they may feel something that's moving. Here you can see a CT scan, just a slight fracture over there. Here you can see on X-ray the displacement of the coccyx as well. So it is a very painful fracture. The majority of them are treated quite conservatively. The only time you really need to worry about coccyx fractures is the massive displacement and things like that. But it's very uncommon. It's more very irritating, painful fracture, if I can put it that way, because your patient is unable to sit and unable to sit with any sort of comfort for a long period of time. So that's one of the things that you need to look at. Okay. And let's go through one more, and let's see what we can see. So what type of fracture do you see? That's what you've got to look at. So I'll give you a second. I think you should just pause the video if you have a chance, and maybe just have a look and see what do you see, and where do you think the forces have been directed. Okay, so if you've had a look at it, then you'll notice that we have an acetabular fracture. We have a sacroiliac fracture, and I think we've got a little fracture of the wing over there. You can see it from here. I can't trace the line up, but I won't be surprised if there is a line. So you have a force that's basically coming from this side. So it's caused an anterior rotation, okay, and fracture along over there. Now I'm just putting it there. I mean, of course, it could have been from anywhere on this side, but it's most likely from there. Here you can see a slight compression. So the symphysis pubis seems to be, a bit compressed and moved a bit medially, especially from this side. But this can also be a rotational effect. And if you were to do a CT, you might well see that there's slight rotation of the symphysis pubis as well. So that was just a small exercise to have a look at. Okay, so like I say, it's impossible to do complete justice to pelvic injuries. That's just a joke to finish on. it's impossible to do complete justice. I mean, this is the type of thing that you could spend a month studying, but just to give you guys a basic grounding in how you look at pelvic fractures and how you actually manage them and what you've got to worry about in the acute stage. So in the acute stage, it's very nice to know all of the classifications, to know exactly if it's moved this many millimeters, move that, then you classify it as this and that. It's all very well and good, but it doesn't help your patient. You need to be able to help your patient. So remember the most important things: stabilize the pelvis, treat the hemodynamic instability, look for associated injuries, treat with antibiotics if necessary, start on antibiotics at least. And, of course, everything that goes along with that, you need to take your relevant bloods, you need to order relevant investigations, you need to get orthopedics involved. And of course, even surgery as well, and urology, depending on how extensive the injuries are. So if it's a purely orthopedic pelvic injury, it does go to orthopedics. But with the majority of these, because of the possibility of intra-abdominal injury, very often the surgeons will take the patient as a polytrauma patient and they'll co-manage with orthopedics. So anyway, I hope you guys enjoyed that. And I hope you guys are getting used to using the website. And hopefully you'll have another lecture next week. Okay, keep well, everybody. Bye.